Thank you very much. Good evening, dear colleagues. First, I'd like to thank all the three ESD chairmen for their kind invitation. Also, Dr. Koch for chairing this session. And David Kerr for thinking of me to give this talk about new medical device to monitor the urine pH in stone formers. As you know, it's already been told, around 80% of the stones are calcium-based, so the rest, 20%, are non-calcium based. And they include struvite, uric acid, and cysteine stones. And we also know that there are different situations depending on the promoters and inhibitors leading to these stones. In fact, a kidney stone would be the result of a balance between these promoters and inhibitors, which will determine the urine composition, but two other factors are needed for a stone to form, and these are pH and time. You have already seen a similar slide before, but I don't care talking about it again because I think it's the most important slide of our presentations, I would say, is to reinforce the idea that urine pH is a key factor for stone formation. We know that urine calcium phosphate supersaturation quickly increases at pH higher than 6.2. On the other hand, acid urine pH is the most important factor for uric acid stone formation. In what we could call the protective zone, that is pH in between 5.5 and 6.2, when we are in supersaturation conditions, the calcium oxalate, both mono and dihydrate stones can form, normally by heterogeneous nucleation, the initial core of the stone being either uric acid or calcium phosphate, depending if the pH is nearer to one or another pH stream levels. The importance of the urine pH and its influence on different stone compositions has been well studied. In example, this report from Grasses and co-workers back in 10 years ago, they found that alkaline pH in stones containing hydroxyapatite, calcium oxalate dihydrate, and struvite. Meanwhile, calcium oxalate monohydrate and uric acid stones are found to be related with acid pH. They get to the conclusion that heterogeneous nucleation explains calcium oxalate monohydrate on uric acid at pH less than 5.5. It also explains calcium oxalate dihydrate on hydroxyapatite at pH more than 6. Struvite stones are found when pH is over 6, a little higher. And calcium oxalate monohydrate papillary calculi are independent of pH. So the main conclusion of this study is that an accurate pH determination is very important, and we can accomplish that with Lee control pH method. The fact that some stones with calcium oxalate monohydrate papillary stones are independent of pH could be in line of the conclusions from Wagner and Mohebi that with the so-called idiopathic hypercalciuria do not display problems in local or systemic pH regulation. Here you have two graphics on the relative effects of urine pH and total uric acid on undissociated uric acid. The dashed line denotes the solubility of uric acid. If you can see, at pH 6.5, even a high level of uricosuric does not significantly elevate undissociated uric acid. On the other hand, at pH 5.5, even a modest concentration of uric acid within the clinical normal range will lead to an dissociated uric acid level that will exceed the solubility. Also, we have diurnal variation of pH and volume in the early hours of morning. Both urine pH and volume are lowest, rendering this a particular vulnerable period for uric acid precipitation. The same example for solubility of cysteine. We can see that its solubility depends on urine pH. The higher the pH, the more soluble the cysteine is. But when talking about urine pH, a critical point is how we determine it. Should we still keep on using the strips to test the pH? Well, we know that lipstick pH measurement is not reliable for guiding clinical decision making, as they carry around 25% risk of producing clinically significant differences from meter values. And we also know the strips also tend to over and underestimate the true pH at high and low urine pH, respectively. We know that dipsticks pH lacks the precision required to guide medical management of stones, and that they lack the accuracy and does not allow to use them in clinical practice to alkalinize or acidify the urine as a prophylactic measure. Grasses and co-workers, again, in this study, found that changes when compared to the gold standard were 0.4 units. Meanwhile, those from the electrochemical sensor were 0.1, concluding that the new pH meter, was the lead control, was reliable, accurate, and is for the patients to handle. Here you have a video on how it works. After pushing once, you see the last pH determination, and the first step will be on the solution buffer, just to set the pH meter, a calibration. Then we change the tape and put it on the urine sample. And just by pressing once the button, in a few seconds, we will have an accurate pH determination of that sample. So it's quite easy for the patient to handle, as you can see. The Koenig and co-workers evaluated in 2018 several methods for pH measurement comparing to the gold standard, which is the professional lab pH meter. They reached the conclusion that lead control portable electronic pH meter was a reliable pH measuring device. Another important issue is the effect that time and temperature and also stone composition have on the pH. Time and temperature are variables we can forget about when using the lead control pH meter, as it can be self-determined by the patient immediately. So time and temperature will not be an issue anymore. Regarding composition, we know that the levels of recommended pH will differ according to the objective of preventing or treating the already formed stones. Here again, it is critical an accurate pH measurement, which can be obtained by using the lead control pH meter. So in conclusions for this first part of the talk, we can say that urine pH is clearly associated with urinary stone formation. It works for all types of lithiasis. There's an optimal level of pH according to type of lithiasis, and lead control pH meter is the best tool to control the urine pH of stone formers. So let me please start with what we call PreventLead study. That was a study that was designed in order to evaluate the utility of lead control pH meter and lithiasis patients management with nutraceutical manipulation of pH. 17 different centers in Spain gathered 143 patients who were followed up for 3 months. We conformed 2 groups. The first one 78 patients from the acidifier group. They were patients with history of calcium stones and a pH at baseline over 6.2. We call that the acidifier group, and they were prescribed 2 capsules a day of lead-controlled pH down, composed of L-methionine and phytate, as you saw previously. The other group, 65 patients with history of uric acid lithiasis and pH at baseline less than 5.5, conformed the alkalizer group. They were prescribed 2 capsules a day of lead-controlled pH up. That is composed of potassium magnesium citrate and theobromine, an inhibitor of uric acid crystallization. In the global study population features, mean urine pH in the acidifier and alkalizer groups were 6.75 and 5.1 respectively. And most of them, as you can see, over 90% in each group, were recurrent stone formers. And 1/3 of the patients with uric acid stones had been under previous pH control therapy. Both nutraceuticals in the results were significantly effective in normalizing pH at all follow-up visits when we compared with the baseline. It was more evident in the alkalizer group, with a maximum percentage of patients achieving non-lithogenic pH at day 60. You can see in these graphics that both lead control pH up and pH down proved to be effective at regulating pH, with significant changes at 1, 2, and 3 months of treatment when compared to basal level. And most importantly, it was an effect sustained over time. Analysis of the effect of treatment compliance at 60 days indicated that 72% of compliant and 46% of non-compliant patients achieved non-lithogenic pH. For those compliants, up to 75% of the patients in the alkalizer group, which were prescribed lead-controlled pH up, reached non-lithogenic pH values at 60 days. Moreover, a causal regression model indicated that non-lithogenic pH at 90 days and compliance at 60 days were independently associated with colic complaints-free survival. So that means that the probability of new stone events dropped more than twice. Regarding satisfaction of the investigators with these products, the control pH up and pH down, it was good or very good in more than 80% of the cases, with a reported tolerance about 90%, whereas adverse effects, all of them minor, gastrointestinal and minor, were registered in less than 9% of the patients. So we can conclude that urine pH is a key factor in stone formation. The pH determination should be performed with a pH meter. Nutraceutics are useful at regulating urine pH, and lead control can decrease the probability of new stone events. Thank you very much for your attention.